Today I'm going to talk a little bit about the new developments in understanding the physiology of transitional hypoglycemia, and then talk about the main forms of pathological hypoglycemia that occur in the newborn period. Talk a little bit about some of the problems with screening, and then I'm going to finish up with the genetic forms of hyperinsulinism and some of the things that we can do in our hyperinsulinism Center of Excellence. So let's start off with transitional glucose regulation. So the pattern of glucose regulation in the first 72 to 96 hours of life has been known for many, many years. And indeed, back in 1965, Marvin Kornblath first demonstrated that babies' blood sugars drop in the first few hours and then steadily rise over the next 72 to 96 hours. And in 2022, the GLOW study replicated this data. So here's the original data from Kornblath, and I want you to focus on this group of babies here, who are the term babies. And over here you have the glucose in milligrams per deciliter. I converted it to millimoles over here, and this is whole blood, so these numbers are plasma, which is what we're more used to today. And what you can see is that in the first 2 hours of life, the blood sugars drop very rapidly, with an average blood sugar being below 60 milligrams per deciliter, or 3.3 millimolar. And then by 24 hours of life, the blood sugars rise, and by 72 hours of life, they essentially match normal adult blood glucose levels. And then almost 50 years later, the same study was done in a group of 77 breastfed babies in New Zealand. And what they looked at was several different things. They looked at the glucose using finger sticks, the glucose using CGM, and they looked at lactate and ketones. And what they showed in terms of glucose is that they were unable to measure in the first 2 hours of life, so they didn't show that drop, but we know that occurs, but that the vast majority of babies have blood sugars just below 60, and then by 48 hours there's an inflection point, and by 72 hours the vast majority of babies have blood sugars over 70 milligrams per deciliter. But notice how there are some babies, even after 48 hours of life, that have glucoses as low as 2 millimolar and definitely below 50 milligrams per deciliter. And so some people interpreted this data in that it is okay if these are normal breastfed babies to have glucoses in the 50s after 48 hours of life, and argued that the guidelines that were produced by the Pediatric Endocrine Society in 2015, suggesting that babies should have blood glucoses greater than 50 in the first 24 to 48 hours of life and greater than 60 after that, were incorrect. So we'll come back and talk about that argument a little later. Now, back in 1954, people first started to realize that neonatal hypoglycemia could be dangerous. And Irving McQuarrie, who gave a speech in 1954, reported this family who had idiopathic spontaneous hypoglycemia in infants. And he demonstrated these two siblings here and showed that their cousins had severe hypoglycemia. And many of these children died, and many of them were severely brain damaged. But it wasn't until really 1976 where Marvin Kornblath reported that this skepticism about whether hypoglycemia could be harmful or not has really been shown, in fact, that it is true. And what he said was that there was evidence emerging by 1970s that about 2 or 3 per 1,000 live birth babies had severe hypoglycemia. And he said that the significance of this hypoglycemia is that if it is allowed to go untreated, the baby may die or develop serious neurological handicap. And what he also noted was that once they realized this and started monitoring normal healthy babies for glucose levels who weren't having symptoms, that lots of those normal healthy babies in the first 12 hours of life had hypoglycemia. And so he developed a classification of hypoglycemia back in the 70s. And he developed 4 categories. The first category was early transitional adaptive hypoglycemia. And so he realized that after babies are born, their blood sugar drops, and then the baby adjusts to extrauterine life, the blood glucose rises, and that was the graph I showed you earlier. He also noted that there was a secondary hypoglycemia. So some babies who had perinatal stresses developed hypoglycemia, and that they were more serious. And a third category was those who had a transient hypoglycemia in the newborn period, and he noted that they were more often born with intrauterine growth retardation, had toxemia, the mothers had toxemia of pregnancy, and that there was a much higher proportion of males than there was females. And he also noted that this hypoglycemia was more severe and it lasted longer, and many of these babies needed a glucose infusion rate of 8 to 10 milligrams per kilo per minute. And then he reported category 4, which is severe persistent hypoglycemia, in which very specific therapies we're talking about. So it turns out in this case he was talking about kids with hyperinsulinism, kids with fatty acid oxidation defects, and all of the genetic forms of hyperinsulinism. So just like I showed you how the development of the understanding of the levels of hypoglycemia has not really changed over the years, as one wouldn't really expect it to, neither has the classification of hypoglycemia. So the modern classification is now divided into 3 groups, and the main difference is that this transient perinatal stress hypoglycemia is a combination of Kornblatt's category 2 and 3. And so it's the infants of diabetic mothers, babies born with intrauterine growth retardation, and babies who underwent either maternal or fetal stress factors. But the most common is transitional glucose regulation, and some studies recently have elucidated the mechanism of transitional glucose regulation, and it is a form of hyperinsulinism, and I'll talk to you about that in a minute. And again, we've better now defined the forms of persistent hypoglycemia, the genetic and syndromic forms of hyperinsulinism, multiple pituitary hormone deficiencies, the glycogen storage diseases, the fatty acid oxidations, and the rare metabolic conditions. So let's talk a little bit about the physiology of transition. So intrauterine growth glucose regulation occurs by facilitated transport of glucose to the fetus across the placenta. And so because it's facilitated, if the fetus has a lower glucose level than the mother, then there's greater flow across the placenta. And this lowering of the glucose in the fetus is driven by insulin secretion. And so what we know is that in the fetus, the threshold to secrete insulin is lower than the threshold to secrete insulin in babies and adults. And as a result, for any given glucose, there is more insulin being secreted. And in utero, insulin is the #1 growth hormone. Its function is for growth, not for glucose control. And in fact, the fetal pancreas is unable to change the amount of secretion of insulin rapidly as it does in the newborn baby or adults, because again, its primary purpose is anabolism and to drive fuel into the cell. So after birth and the abrupt discontinuation of glucose transfer from the placenta, the plasma glucose drops and very slowly over 24 to 48 hours reaches adult levels. And this occurs because of a reset in the threshold for insulin secretion. And the threshold for insulin secretion is about 80 to 85 milligrams per deciliter in adults, and it's the same in children after about 3 days. But in the immediate newborn period, it's much lower at about 65 to 70 milligrams per deciliter. So that explains why there is this change over time where the glucoses are on the lower side compared to older children and adults, and then gradually from 42 to 72 hours, the glucoses rise. And this is important because it means that we have to interpret glucose levels differently at different hours of life. So you're all very familiar with the concept that a bilirubin level at 12 hours does not have the same significance as a bilirubin level at 72 hours. And so you have beautiful curves that give you the normative value for different ages. And glucose is the same. And it's very important for us to remember that, because a glucose of 52 at 2 hours of life is completely normal, but a glucose of 52 at 72 or 96 hours of life is very abnormal. So if that's the case, then why did the GLOW study show that babies who are normal, healthy term breastfed babies had low glucoses after 48 hours of life? And the answer is because normal, healthy term breastfed babies don't actually feed very much for the first 12 to 24 hours of life. So the newborn breastfed baby is in a degree of starvation. And this can be demonstrated by looking at the beta-hydroxybutyrate levels, which are the hormone. The beta-hydroxybutyrate is a breakdown product of fatty acids and indicates that the patient is fasting. And you can see how many babies by 48 hours of life have beta-hydroxybutyrate levels greater than 1 millimolar. And what the GLOW study showed is that when they paired up the glucose levels that were low, they found they came with the highest beta-hydroxybutyrate levels. And so this indicated that in breastfed babies, there are in fact two different phases of transition. The first phase of transition is due to the relative hyperinsulinism caused by the reset in the threshold to secrete insulin. And the second phase of hypoglycemia is a hyperketotic form of hypoglycemia, which is starvation. So you would not expect to see the second phase in a formula-fed infant. But don't mistake me saying that formula is better than breast. It's not. This is the normal physiology of the normal breastfed baby. And so this explains why some babies have low blood sugars after 48 hours of life. And so to summarize, transitional glucose regulation reflects the transition from a lower in utero threshold of insulin secretion, and it's mediated by the KATP channel on the beta cell membrane, and it is caused by the relative intrauterine hypoxic state of the fetus. And then when the fetus is delivered and they develop a well-oxygenated state, there's increased expression of the KATP channel on the beta cell, and that changes the threshold for insulin secretion. And so physiological transition is a transient form of hyperinsulinism in the first 12 to 48 hours. And that is one of the reasons why the Pediatric Endocrine Society guidelines recommend that you do not look for the cause of hypoglycemia in the first 48 hours, but rather you just treat the baby, achieve the targets of, greater than 50 for the first 12 to 24 hours and greater than 60 after that. And then if the baby has persistent hypoglycemia, only then do you start to evaluate and look for the cause. So we've talked now all about the normal physiological transition, and I've introduced you to the pathological conditions, or what we call pathological hypoglycemia. And that's all the other forms of hypoglycemia other than transitional hypoglycemia. And so it's very important as a neonatologist and a pediatrician taking care of babies in the newborn nursery is to determine, is this child who has a blood sugar of 50 or 2.7 millimolar at the age of 72 hours, is this physiological or is it pathological? And so we'll talk a little bit about a quick screening test that you can do that's very helpful. But first, let's talk about how frequent is pathological hypoglycemia. So the genetic forms of hyperinsulinism occur in about 1 in 25,000. I apologize, we lost a zero there. Hypopituitarism is at about 1 in 25,000 babies. The glycogen storage diseases are even rarer, about 1 in 50 to 100,000 babies. And the fatty acid oxidation defects, about 1 in 10,000. So if you look at the rare genetic diseases, about 1 in 5,000 babies will have a rare genetic disease that causes hypoglycemia. However, acquired hyperinsulinism or perinatal stress hyperinsulinism occurs in about 1 in 1,200 to 1 in 2,500 babies, depending on the reports. And so this gives you a frequency of about 1 in 1,000 babies will have a serious form of hypoglycemia or a pathological form. And then if you look at babies who have neuroglycopenic symptoms of hypoglycemia, such as seizures, lethargy, coma, all of those babies will always have a pathological form of hypoglycemia. So if you're called to evaluate a baby with seizures and hypoglycemia, that baby has a serious underlying disorder, and our job is to identify the cause before they go home. And it's important to remember that many of the causes may be transient, as I mentioned before, so it's very important that if you believe it's transient, that you prove that the condition has resolved spontaneously. So, what do the main causes of neonatal hypoglycemia have in common? And again, here are the 3 categories that we've talked about. And the single most common thing that they have is low plasma ketones. So it turns out that we can use low plasma ketones as a very useful tool to differentiate between physiological hyperketotic hypoglycemia that occurs in the breastfed baby from pathological hypoglycememia. So if you have a baby who is more than 48 hours of life and is having intermittent or persistent glucose is less than 60 milligrams per deciliter, then you can measure a plasma beta hydroxybutyrate. And if there's a low glucose with a high ketone level, this is almost certainly physiological. And so you would perform a history and determine that this is a healthy term baby. The mother is breastfeeding, her milk hasn't come in, maybe the baby's lost 4 or 5% body weight. And they're not voiding a lot. So you would say, okay, this is a starved breastfed baby, all we need to do is feed him. On the other hand, if the glucose is low and the ketones are low, then more likely this is a pathological form of hypoglycemia and needs further investigation and diagnosis. So, one of the big problems about screening for hypoglycemia in the newborn period is that the AAP guidelines really only guide you on what to do in the first 24 hours, and the PES guidelines will guide you on what to do for the first 72 hours and onwards. And so you really have to take a combination of both sets of guidelines in order to do everything the way it needs to be done. So I think the first step is in a baby who's got low glucose is measure the ketones. Now, ketones can be measured by point-of-care meters. In the US, there is one single FDA-approved inpatient point-of-care ketone meter, but most chemistry labs can measure beta-hydroxybutyrate on the same machine that measures a comprehensive metabolic profile or sodium or potassium. It just requires a different cassette. So it's very useful to be able to do this in your NICUs because you can save the vast majority of babies that you're going to see are going to have a physiological hypoglycemia. So you can save doing a lot of investigations if you can do that. And then the second thing to do is basically follow the PES recommendation, which is you need to investigate everyone who needed IV dextrose to treat their hypoglycemia, everyone who has neuroglycopenic signs of hypoglycemia, anyone who has a clinical syndrome consistent with hypoglycemia. So by that I mean something like Beckwith-Wiedemann syndrome. So if a baby has Beckwith-Wiedemann syndrome, you need to monitor their glucoses carefully. And if someone comes in and says that my first child had hyperinsulinism and had to have a pancreatectomy, then you really need to look at that child, the next child, very carefully. And our job as neonatologists are primarily to make sure that there is no pathological etiology for the hypoglycemia prior to discharge, and then typically once you determine that that child has a pathological problem, that's primarily where the endocrinologists and metabolic physicians come in and help out. So I'd like to change over for the last 10 minutes and talk a little bit about hyperinsulinism. This is a condition in which insulin secretion is uncoupled from glucose sensing, and so you have inappropriate insulin secretion that leads to hypoglycemia. The clinical features are that there's a profound and persistent hypoglycemia. It typically presents in the first 24 hours of life, so this is the same time that babies with physiological transition are having lower blood sugars, but these kids typically don't respond to feeding. They need glucose infusions. They have very low beta-hydroxybutyrate and lactate levels. And what's important about this is that 20 to 40% of the babies have brain damage. And so it's very important for neonatologists and pediatricians caring for newborns to have a plan how to differentiate hyperinsulinism from normal. And again, the simple test is the beta-hydroxybutyrate. Now, the treatment of hyperinsulinism is to maintain the glucose greater than 70 milligrams per deciliter or 3.7 millimoles with intravenous glucose. If the hypoglycemia is persistent, then you use diazoxide and start at a low dose. If you think this is perinatal stress hyperinsulinism, I would start even lower at 2.5 milligrams per kilo per day. But if you think it's a genetic form, start at 5 and then increase by 5 milligrams per kilo per day every 3 days up to a max dose of 15 if you're unable to wean off the IV dextrose. You want to start a diuretic at the same time and monitor for the side effects of diazoxide, which are fluid overload and pulmonary hypertension and neutropenia. And then if you're able to wean off the IV dextrose, then you need to do a safety fast to demonstrate that the child is able to fast 6 to 9 hours, and so they can go home and follow up with the endocrinology in the outpatient. However, if you give the diazoxide and 5 days after you're on the maximum dose, they continue to need IV dextrose, then they have diazoxide unresponsive hyperinsulinism, and the most likely cause of that is KATP channel hyperinsulinism. And so we think about hyperinsulinism as either diazoxide responsive or unresponsive. And if it's responsive, you do the fasting study, and if the baby's able to keep his blood sugar over 60 or 3.3 millimolar for 9 hours, then they're safe to go home. For those that are not diazoxide responsive, now you're into the likelihood that this is a KATP channel disorder, and what's important about that is there are two types. There are those children who have diffuse disease where the whole pancreas makes too much insulin, and those who have focal disease where only a small part of the pancreas makes insulin. And if you're blessed enough to have access to genetic testing and 18F fluorodopa PET scan, then you can differentiate which patients have which. And the reason that's important is that surgery can cure the focal patients but does not cure the diffuse patients. So you have an opportunity in about 50% of the diazoxide unresponsive patients to have focal disease and thus cure them. And the genetics of how focal occurs is a little complex, but in essence, for diffuse disease, you inherit an autosomal recessive mutation from the mother and the father, and so it's in the blood, it's in the pancreas, the whole pancreas makes too much insulin. However, in focal disease, there's no mutation on the maternal allele, but the paternal allele has a mutation, and in the focal lesion there's loss of part of maternal chromosome 11, so you're left with only one mutated gene, and thus you get abnormal insulin secretion. And so you can imagine how if you could find that focal lesion and remove it, you could cure the patient. And so the way to find the focal lesion is to perform 18F-DOPA PET scan. And here you can see an 18F-DOPA PET scan in a diffuse patient. Here's the kidneys, here's the other kidney, the bladder. You can see the liver here, and this is the pancreas. And you can see that there is increased uptake throughout the whole of the pancreas. Whereas in the focal lesion, you've got your kidneys, your bladder, your diaper that the baby peed in, your liver, and here you can see at the tail of the pancreas is the focal lesion. And so the surgeon goes in, removes the focal lesion, and the patient is cured. And so this is why it's important, because we can cure the patients with focal disease. So in conclusion, hyperinsulinism is the most dangerous form of hypoglycemia, and both the acquired or transient forms of hyperinsulinism and the genetic forms of hyperinsulinism all have a risk of brain damage of 20 to 40%. And this is primarily because of the severe hypoglycemia that can occur prior to making the diagnosis of the etiology, because once you start to treat the patient, put them on IV dextrose plus feeding, then you can control their blood sugar and the risk for harm is less. If you have diazoxide unresponsive hyperinsulinism, this is almost always due to the KATP channel genes, and the two types of that, the focal form is curable, so doing genetics and a PET scan is important. Now, I say that, however, there's only 2 centers really in the United States who can do PET scans and cure the focal disease, and it's even less available worldwide. So this is tough for those of you who don't have access. But one solution would be that if you find you have a patient with focal disease, who has one mutation in the KATP channel and it comes from the dad, then if you can't do imaging, and I believe that in different countries in South America, the PET imaging is available, but if you can't do it and you have no option but to do surgery, then what you need to do is to start at the tail of the pancreas and remove small amounts of the pancreas and have your pathologist look at them under frozen section to see, was this a piece of normal tissue you took out, or was it a focal lesion? And if it's a focal lesion, did you get the whole part of it out, or do you have to take a little more? And in that case, you know, just by statistics alone, 50% of the babies with focal disease will have a lesion in the body and the tail. So if you're able to find it in 50% of the focal kids, you can cure them without doing a 98% pancreatectomy. So if you don't have the PET imaging, get your pathologist to train in how to do frozen sections and how to recognize the difference between focal and disease, focal and diffuse. Okay, so I'd like to thank this is my hyperinsulinism team, and I appreciate you listening, and I'm happy to take any questions, and I can take them in Spanish or English because I have my translation device up here.